Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So, we're hitting time to start to transition to question and answer. With that, I want to invite our audience to keep putting the questions in. There's already a handful of really excellent questions, and we'll go through all of them. I do want to remind my panelists and myself and beg forbearance from our audience that we're not able to offer medical advice. But as Cancer Grace has done for a decade, gosh, it's more than a decade and a half plus, we will give targeted information. And please forgive us if it doesn't quite get as narrow as you might like. That's not our decision. That's what's allowed. As we, at least I'll speak for myself, I probably don't have a license to practice medicine in your state. So we have a theme of questions here about who to test. So maybe we can start with those up front. I think one thing to answer easily that I don't need to put to the panel is that every patient with stage 4 non-squamous non-small cell lung cancer should have molecular testing. This is irrelevant of race, irrelevant of sex, irrelevant of smoking history. The one way back when there were clinical profiling that had some utility in a pre-molecular era, it is now useless, right? That's easy. But I'll start with a question that gets at this theme. Did I hear correctly that next-gen is only recommended for non-squamous non-small cell lung cancer? Can squamous cell non-small cell lung cancer have targetable mutations?
Well, I'm happy to start with this. It is interesting that if you read the guidelines, they keep softening over time with regard to squamous. It used to be that NCCN would say, oh, you don't need to do broad molecular profiling for, squamous cell lung cancers. And then, a year or two ago, the guidelines said, well, you can consider, broad molecular profiling in squamous cancers where you suspect they might have an actual mutation where, if someone has a limited smoking history, for instance, and has a squamous histology. And then now the most current NCCN guidelines actually, recommend consider, broad molecular profiling those with squamous histology. I think, the reality is that, squamous patients do have actual mutations, that some of these have nothing to do with, your long smoking history. And so I think increasingly, more and more, we're going to start to sequence squamous cell patients.
I think back in the day, sequencing was difficult. Sequencing was stupidly expensive. I think it's relevant that the cost has come down, the technology has become easier to access. I will share as well that there is a bit of a literature on actionable mutations in squamous histology. There are at least 2 papers out of China where EGFR mutation is far more common on EGFR mutation in patients with squamous disease. It's less common than an adenocarcinoma. I wish I could say drug worked as well in that literature and that we were in a purely molecular era, but that's not actually what those papers showed. Their response rate was roughly half, but still it looked like, at least for the time, that it was edging out chemo. I think that in a world with infinite resources, or let me rephrase that, in a world where insurance allows it, it's perfectly reasonable to test a squamous patient. In my opinion, it's mandatory if there's any doubt about the histology. So if there's any question of whether it's purely squamous, I think it's mandatory. If it's a mixed histology, I think it's rather mandatory. And this might be a little bit more controversial. I want to be clear. I love my smokers, former smokers, never smokers, all the same. Here at Grace, we're not here to stigmatize anyone, but there is a difference in probability of finding something actionable in a patient who smoked and a patient who hasn't. And so if I have a patient who's never smoked or has a very light former smoking history with squamous, I'm going to push a little bit harder to getting that testing. I don't think it's wrong, though, to test any squamous patient, I think there just needs to be honest counseling that insurance might not pay for it. And so that needs to be put out in advance, and you need to get a financial counselor involved to make sure that if a patient elects for that testing, that they understand the potential financial toxicity implications. But if I have a patient with 50 pack-year smoking history, I'm exaggerating on purpose, and clear squamous histology, who can afford it and wants molecular testing, I have no issue with that, and I would offer it.
Yeah, and I think one thing to highlight, and it's been clear across the 3 talks this morning, is that the field and the practice of lung cancer is advancing. It's evolving continuously. So the answer today may not be the answer tomorrow. And I say this to highlight that we are starting to learn that there are some molecular alterations that we do see kind of equivalently in squamous versus non-squamous. As an example, something like MET exon 14 skipping may be more relevant. And I think that our goal as oncologists is to find targets for everyone. And so as that pie starts to fill in and grow, I do think that, and as you have more viable therapies and something to pair someone with, I think that we are going to start more broadly extending molecular testing to all populations. But I think right now, the key points that you've highlighted, that it's unlikely to impact care for the majority of patients. And I think those time pressures that we talked about waiting for the results versus starting therapy, I think I would be less inclined to defer or delay therapy in that setting.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.